Welcome back to the deep dive. Today we are tackling, well, a really ambitious mission, I think. We want to move past just the social idea of ethyl alcohol, ethanol, and really treat it as what it is,
Yeah.
a potent pharmacological substance.
Absolutely. It's shaped history, it dictates a lot in forensic science, and knowing how to handle it medically is, frankly, life-saving sometimes.
It's arguably the most widely used drug globally,
Mhm.
yet, public understanding often stops at the surface.
Right. So our goal today is different. We're aiming for what you might call elite professional mastery, really getting under the hood.
We're going deep into its chemistry, that unique zero-order metabolism, which is fascinating. Its specific targets in the brain's reward system.
And crucially, understanding the deadly difference between ethanol and its toxic cousins, like methanol, that's vital.
Our sources are pretty comprehensive. Digging into the pharmacology, the kinetics, the toxicology, we plan to cover pretty much everything. From the basic fermentation reaction,
Zymase. Yeah.
right through to the receptor mechanisms,
Yeah.
GABA and MDA.
And even the specific antidotes for poisoning. It's a big landscape.
So before we get lost in the weeds, let's just quickly define our terms chemically. What actually is an alcohol?
Fundamentally, it's a hydroxy derivative of an aliphatic hydrocarbon. But for this discussion, when we just say alcohol, we almost always mean ethyl alcohol. Ethanol, C2H5OH.
And its role today is overwhelmingly non-medical, right?
Yeah.
But its history is tangled up with intoxication.
Completely. Understanding its effects, intended or not, is woven into human history. Hashtag 22, the chemistry, production, and variety of beverages.
Okay, let's get into production. The sheer scale of ethanol production relies on a pretty basic biological process, fermentation.
It does, and the
Okay.
core reaction is ancient, biologically speaking. You start with glucose, maybe from starch or sugar sources,
Right.
and an enzyme complex found in yeast called zymase breaks it down
To do.
into two molecules of carbon dioxide, that's the bubbles in beer and champagne, and two molecules of ethanol. Glucose goes in, CO2 and ethanol come out.
But there's a natural limit, isn't there? Something people often get wrong. Fermentation can't just go on forever.
No, absolutely not. Nature has a built-in stop sign. The process halts when the alcohol concentration hits about 15%.
Why is that?
Because the ethanol itself becomes toxic to the yeast that's producing it. It's a form of self-poisoning, really.
Ah, okay. So that 15% is a kind of biological ceiling for natural fermentation.
Exactly. Which
Yeah.
is why your standard beers and wines, made just by fermentation, can't naturally go above that level without some kind of intervention.
And getting those sugars in the first place. Cereals like barley are common, right? Soaking them produces malt.
Yep, malting converts the starches into sugars the yeast can actually work with. But for huge industrial production,
It's something else.
it's mainly molasses, that thick, dark syrup left over from sugar refining.
Why molasses?
It's cheap, it's readily available, and it's packed with residual sugar. So very efficient for making large quantities of ethanol.
Okay, so we have this 15% natural limit. Let's talk about the different beverage categories based on how they relate to that limit.
We can group them into broadly 3 types.
First up, malted liquors, like beers and stouts.
Right. These are undistilled. They rely solely on that initial fermentation. So the alcohol content is pretty low, usually 3 to 6%.
Those some craft beers push that higher now, maybe up to 10%.
Yeah, brewing techniques have evolved, but they're still fundamentally just fermented, not distilled.
Okay, next category, wines, also undistilled.
Correct. Fermenting natural sugars, usually from grapes or other fruits. And here again, that 15% cap is sort of the natural maximum.
So light wines, claret, cider, they sit in what range?
Typically 9 to 12%. They can't really exceed 15% naturally.
But then you have fortified wines, port, sherry. How do they break that 15% barrier and hit, say, 16 to 22%?
That's the intervention. They add distilled spirits, basically concentrated ethanol, to the wine base. They fortify it.
Got it. And what about bubbly wines like champagne? How do they get their fizz?
Ah, that's about trapping the CO2. They bottle the wine before fermentation is totally complete. The yeast keeps working a bit, releasing CO2, but now it's trapped in the bottle, creating the effervescence, usually around 12–16% alcohol.
And quickly, those terms dry and sweet wine, what's the difference there?
Simple enough. Dry means the yeast consumed pretty much all the sugar. Sweet means some residual sugar was left behind unfermented.
Okay. Finally, the high proof stuff. Spirits, rum, gin, whiskey, vodka.
This is where distillation comes in. You take the fermented broth, the wash, which is maybe 10–15% alcohol,
Yeah.
and you heat it. Alcohol boils at a lower temperature than water, so the vapor is much richer in ethanol. You condense that vapor and boom, much higher concentration.
Typically in what range?
Usually 40 to 55% alcohol by volume, although for consistency in trade and, legal standards.
There's often a standard.
Yes. Internationally and in places like India, it's often standardized to 42.8% volume by volume. That works out to about 37% weight by weight, WW.
Now, this is interesting. The appeal isn't just the alcohol kick, right? An aged whiskey is worlds apart from a neutral vodka. What creates that difference?
It's all about the congeners and the maturation process. The value, the character, comes from trace amounts of other compounds formed during fermentation and especially during aging, often in wooden barrels.
Like what kind of compounds?
Higher alcohols, esters, aldehydes, volatile oils, even polymers leached from the wood. These develop over time and create the unique flavor, aroma, and color profiles.
Yeah.
That's the art of maturation.
Okay, let's shift to the more technical or industrial forms of alcohol. These definitions are pretty important in labs or industry.
Absolutely. Precision matters here. First, absolute alcohol.
Which is?
Essentially pure ethanol, 99% weight by weight. It's been dehydrated to remove almost all the water.
Then there's rectified spirit.
That's the standard product from distillation, usually a fermented molasses, typically around 90% ethanol by weight.
And the historical one, proof spirit. This has a great story behind it.
It really does. It goes back to the 17th century British Navy needing to check if the rum ration they bought was watered down.
How'd they test it?
The gunpowder test. They'd mix the spirit with a bit of gunpowder and try to light it. If it was too weak, too much water, the gunpowder wouldn't ignite.
But if it did ignite?
Then it was proved to be strong enough. That threshold strength became the standard.
And that translates to a specific concentration today.
Yes. 100% proof spirit isn't 100% alcohol. It's precisely 49.29% ethanol by weight or 57.1% by volume. That proof system still lingers, especially in the U.S.
Fascinating. Lastly, and this is critical because of the toxicity difference, methylated spirit or denatured spirit.
Right. This is industrial alcohol made unfit to drink on purpose. They take rectified spirit, about 95 parts, and add about 5 parts of wood naphtha, which is crude methyl alcohol, methanol.
Add a dye, too.
Yep. Tinted blue with methylene blue dye, usually, as a visual warning. It's strictly for external use, antiseptic, cleaning fluid, astringent. You absolutely cannot drink it because of the methanol. We'll come back to methanol toxicity later. It's a whole different beast.
Okay, now for the core of it, how does ethanol actually interact with the human body? Let's go system by system, starting with local actions, like on the skin.
Locally, on the skin, it acts as a mild rubefacient, causes a bit of redness if you rub it in, and a counter-irritant.
And it feels cool, right?
Yeah, that's just rapid evaporation pulling heat away. It's also an astringent.
Meaning?
It precipitates surface proteins, makes the skin feel tighter, harder. That's why it's sometimes used to prep skin for taping or to help manage bed sores.
Now, the antiseptic action, you mentioned a paradox here about concentration. It's not just stronger is better.
Exactly. This is counterintuitive. Antiseptic effectiveness increases as you go from about 20% up to 70% ethanol. It stays pretty good up to 90%. But then it decreases above 90%. Pure 100% ethanol is actually a worse antiseptic than 70% or 90% solution.
Why is that? Why isn't pure ethanol the best killer?
Because its action isn't just dehydration. Water is actually needed for the alcohol to effectively penetrate the bacterial cell wall and denature the proteins inside the cell.
Ah, so 100% alcohol just seals the outside.
Pretty much. It instantly coagulates the surface proteins, forming a barrier that stops the alcohol from getting deeper into the microbe. Also, importantly, alcohol doesn't kill bacterial spores, regardless of concentration.
Okay, and internally, concentrated alcohol is obviously not good.
Definitely not. It's highly irritating to mucous membranes. Think inhaling fumes from strong spirits. It burns. If injected under the skin, it causes severe pain, tissue death, necrosis, and scarring.
But that destructive property is sometimes used medically.
Yes, in specific controlled situations. For intractable pain, like from nerve damage or certain cancers, a doctor might carefully inject concentrated ethanol around a nerve.
To deliberately damage it.
Precisely. It causes permanent nerve damage, destroying the nerve fibers transmitting the pain signals. It's a last resort, but can provide significant relief. #BP, central nervous system, CNS, the core depression.
All right, let's get to the main stage. The brain. The central nervous system. Despite the initial feeling of excitement or euphoria, alcohol is fundamentally
a neuronal depressant, a CNS depressant, through and through.
So the buzz or high isn't stimulation?
No, it's an illusion caused by disinhibition. At lower concentrations, say 30, 60 milligrams per deciliter in the blood, ethanol preferentially dampens the highest, most complex brain regions first.
The parts responsible for control.
Exactly. The inhibitory centers that manage things like caution, self-criticism, judgment, social restraint. When those get suppressed, the underlying impulses seem more prominent. You feel less inhibited, maybe more talkative or bold, but it's because the brakes are coming off, not because the engine is revving up.
Understanding the effects at different blood alcohol concentrations, BAC, is key to grasping the danger. Can we walk through that?
Sure. It's a pretty predictable gradient, 50 on 100 milligdl. This is often around the legal driving limit. You feel high, mood changes, coordination and judgment are subtly off.
Okay.
100 and 150 milligl. Now, mental clouding is obvious. Attention, memory are impaired. Gait might become unsteady. Drowsiness starts creeping in.
Getting more serious.
150, 200 milligdl, frank intoxication. Speech is slurred, balance is poor. That's ataxia. This is also the range where blackouts often happen.
Blackouts meaning?
Periods where the person is conscious and interacting, but their brain isn't forming long-term memories. They'll have no recollection later. Anterograde amnesia.
Right. Keep going.
200, 300 milligdl stupor. The person is very difficult to wake up, responds only minimally.
And beyond that.
Above 300 milligdl, this is critically dangerous territory. Unconsciousness leading to suppression of the medulla oblongata in the brainstem.
Which controls vital functions.
Breathing and heart rate, yes.
Yeah.
Medullary paralysis leads to respiratory failure, coma, and death. The margin for anesthesia is very narrow and unsafe.
So even well below lethal levels, performance is shot. Driving, operating machinery.
Absolutely impaired. Reflexes slow down, decision-making is poor, fine motor skills degrade. There's really no safe level for complex tasks.
You mentioned a caveat, though, where anxiety was already impairing performance.
Yeah, it's a niche situation. If someone is so anxious or fearful that their anxiety is crippling their performance, alcohol might temporarily seem to improve things by reducing that overwhelming anxiety. But the underlying physiological impairment from the alcohol is still there. It's masking, not enhancing.
And what about acute tolerance? The effects feel different depending on whether BAC is rising or falling.
Yes, this is important, especially for, say, roadside testing. The impairment, the subjective feeling and objective signs are more pronounced for a given BAC when the level is rising compared to when it's fallen.
So someone might seem less drunk at 100 milligdl on the way down than they did at 100 milligdl on the way up.
Correct. The brain starts to adapt relatively quickly. Doesn't mean they're safe to drive, of course, but the outward signs might be less dramatic as the concentration drops.
And chronically, long-term heavy drinking does physical damage.
Undeniably. It's neurotoxic. Chronic abuse leads to measurable brain shrinkage, actual loss of brain mass. The cortex, responsible for higher thought, and the reticular activating system involved in arousal seem particularly sensitive. ####, see mechanism of action. The receptor level detail.
Okay, let's get really specific now. Beyond just saying CNS depressant, what is alcohol actually doing at the molecular level in the brain? We need that elite understanding.
Right. We've moved past older ideas like it's just dissolving in cell membranes. At the concentrations relevant to intoxication, ethanol acts on specific protein targets, mainly ion channels and receptors.
Let's start with the inhibitory side. The GABA system seems key.
It's a major player. Ethanol enhances the action of GABA, particularly at the GABA receptor. GABA is the main inhibitory neurotransmitter in the brain.
How does enhancing GABA cause depression?
When GABA binds to the GABA receptor, it opens a channel allowing chloride ions to flow into the neuron. This makes the neuron less likely to fire an electrical signal. Ethanol basically boosts this braking effect. More inhibition, more CNS depression.
Okay, so it pushes the brakes. What about the accelerator, the excitatory systems?
It slams the brakes on those too, particularly the NMDA receptor.
NMDA. That's involved in learning and memory.
Exactly. N-methyl aspartate receptors are crucial for synaptic plasticity. Ethanol is a potent inhibitor of NMDA receptors.
So it's a double whammy. Boosting inhibition via GABA and reducing excitation via NMDA.
Precisely. And that NMDA inhibition is thought to be strongly linked to the cognitive deficits, the memory problems, and especially the blackouts seen with alcohol.
Are there other channels involved besides those two main ones?
Yes. Ethanol also inhibits certain voltage-gated calcium channels in neurons. Calcium entry is vital for releasing neurotransmitters, so blocking these channels further dampens neuronal communication. It also seems to potentiate the action of serotonin at the 5-HT3 receptor subtype, which is an inhibitory receptor, and it interacts with certain nicotinic acetylcholine receptors as well. It's hitting multiple targets.
Now, the big one for addiction, the reward pathway. Why does alcohol feel good? Why is it reinforcing?
This is crucial for understanding dependence. Alcohol triggers a release of dopamine, DA, in a key part of the brain's reward circuit, the nucleus accumbens.
That's the feel-good chemical signal.
Largely, yes. That dopamine surge is strongly associated with pleasure and reinforcement, making you want to repeat the behavior.
How does alcohol cause that dopamine release? Is it direct?
It seems indirect. The evidence points to alcohol causing the release of the brain's own opioids, specifically beta-endorphin. These endorphins then act on opioid receptors, and that leads to the dopamine release in the nucleus accumbens. It's an opioid-dependent mechanism.
Fascinating. So it hijacks the brain's natural reward system using endorphins.
That seems to be a major part of its reinforcing effect and the drive towards dependence.
And does alcohol's influence stop at the receptors on the cell surface?
No, it goes deeper, affecting intracellular signaling. It's known to alter the activity of enzymes like Na plus K plus ATPase, the sodium-potassium pump, and adenylase cyclase, involved in making cyclic AMP a key messenger molecule.
So it's messing with the cell's internal machinery, too.
Yes, and it affects protein phosphorylation, the process of adding phosphate groups to proteins to switch them on or off via pathways involving protein kinase C, PKC, and protein kinase A, PKA. These changes contribute to the longer-term adaptations in the brain associated with tolerance and dependence. #D cardiovascular system, CDS.
Okay, let's look at the heart and blood vessels. How does alcohol affect the cardiovascular system? Does dose matter here, too?
Very much so. At small doses, the main effect is vasodilation, particularly in the skin and stomach lining.
So that's the warm, flushed feeling. And maybe red eyes.
Exactly. Cutaneous vasodilation brings blood to the surface. Conjunctival injection is the red eyes. At these low doses, blood pressure isn't usually affected much.
What happens with moderate doses?
You might see a slight increase in heart rate, tachycardia, and potentially a mild rise in blood pressure. This isn't a direct effect on the heart muscle itself, usually.
What causes it, then?
It's thought to be secondary to general sympathetic nervous system stimulation, maybe linked to the initial excitement phase or just increased muscle activity.
But large, intoxicating doses are different.
Very different. At high concentrations, alcohol directly depresses the heart muscle, myocardium, and also suppresses the vasomotor center in the brainstem that controls blood vessel tone,
Leading to.
a dangerous drop in blood pressure and potentially cardiovascular collapse.
And the chronic effects. Long-term heavy drinking isn't good for the heart, right?
Definitely not. Chronic excessive alcohol use is a major contributor to hypertension, high blood pressure. It can also directly damage the heart muscle, leading to alcoholic cardiomyopathy, a weakened and enlarged heart.
Any other chronic heart risks?
Yes, it increases the risk of atrial fibrillation, an irregular heartbeat, and can cause abnormalities in the heart's electrical conduction, sometimes seen as QT prolongation on an electrocardiogram, ECG, which carries a risk of dangerous arrhythmias. #E, blood, and metabolism.
You know, there's this widely discussed idea about moderate drinking being protective for the heart. What's the science behind that?
There is epidemiological evidence suggesting that consuming, say, 1 or maybe 2 standard drinks per day is associated with a lower risk of coronary artery disease.
What's the proposed mechanism? How would alcohol protect arteries?
The main theory involves lipids. Alcohol appears to raise levels of HDL cholesterol, the good cholesterol,
Right.
and it might also decrease the oxidation of LDL cholesterol, the bad cholesterol. Oxidized LDL is thought to be more damaging to artery walls.
And the numbers on that risk reduction.
Some studies suggest a 15 to 35% lower incidence of CAD in light to moderate drinkers compared to non-drinkers or heavy drinkers.
But there's a big but here, isn't there? This isn't straightforward advice.
Absolutely not. First, that potential benefit is completely lost, and in fact reversed, if consumption goes above about 3 drinks daily. Heavy drinking increases cardiovascular risk.
And advising non-drinkers to start.
Generally not recommended by most health bodies. The potential harms of alcohol addiction risk, accidents, liver disease, certain cancers, the hypertension we just mentioned likely outweigh this modest potential cardiovascular benefit for many people, especially if they don't drink already. It's a complex risk-benefit calculation.
Right. What about other effects on the blood? Anemia.
Mild anemia is pretty common in chronic alcoholics, often linked to poor nutrition, but a more specific type is megaloblastic anemia.
What causes that?
Alcohol directly interferes with the metabolism and absorption of folate, vitamin B9. Folate is essential for making DNA and for the proper maturation of red blood cells. Without enough functional folate, red cells become large and abnormal, leading to megaloblastic anemia. Hashtag F. Other systemic effects. Comprehensive review.
Let's cover some other body systems. Temperature drinking makes you feel warm, but is that actually helpful in the cold?
It's deceptive and dangerous. The feeling of warmth is just blood rushing to the skin due to vasodilation, but that actually increases heat loss from the body core to the environment.
So drinking before going out in the cold is a bad idea.
A very bad idea. You'll lose heat faster and increase your risk of hypothermia. High doses also directly depress the brain's temperature-regulating center in the hypothalamus, further impairing the body's ability to cope with cold.
What about breathing? Does a shot of whiskey really stimulate respiration if someone's collapsed? Old movie trope.
Pure myth and dangerous advice. Any fleeting gasp reflex might be from irritation of the throat lining, not central stimulation. The direct effect of alcohol on the respiratory center in the brainstem is depression. Giving alcohol to someone with depressed breathing will only make it worse.
Okay, the gastrointestinal GI tract. Alcohol's effect seems variable.
It is, and very dose-dependent. Interestingly, dilute alcohol, around 10% concentration, is actually a potent stimulant of gastric acid secretion.
So a little bit might aid digestion.
Potentially. But go higher, above 20% concentration, and it flips. It inhibits acid secretion, causes inflammation and congestion of the stomach lining, gastritis, and often triggers nausea and vomiting.
And it affects the esophagus too.
Yes, significantly. Alcohol relaxes the lower esophageal sphincter, LES, the muscle valve between the esophagus and stomach. This makes acid reflux, or GERD, much worse.
And pancreatitis risk.
Heavy drinking is a major risk factor for developing acute pancreatitis, a severe and painful inflammation of the pancreas.
Now, the liver. This is where chronic damage really takes a toll.
It is, though with small or moderate amounts, if the person's nutrition is good, the liver can cope initially without permanent damage. The first change usually seen is fatty liver, steatosis.
How does alcohol cause that?
It alters fat metabolism. It promotes the mobilization of fat from peripheral tissues to the liver, and also increases fat synthesis within the liver. This fat accumulates in liver cells.
Is fatty liver reversible?
Yes, typically it is if the person stops drinking, but chronic excessive drinking pushes things further.
Towards cirrhosis, what's the mechanism there?
It's thought to be multifactorial, but a key culprit is acetaldehyde, the first breakdown product of ethanol. Acetaldehyde is quite toxic.
How does it damage the liver?
It directly damages liver cells, hepatocytes. There's also increased oxidative stress, depletion of protective antioxidants like glutathione. This all leads to inflammation, cell death, necrosis, and eventually the replacement of functional liver tissue with scar tissue fibrosis, which progresses to cirrhosis.
And alcohol affects liver enzymes too.
Yes, regular heavy intake induces or ramps up the activity of certain liver enzymes, particularly the microsomal enzymes like CYP2E1. We'll see why that's important when we discuss drug interactions.
Okay. Endocrine system effects. Hypoglycemia risk during intoxication seems critical.
Extremely critical, potentially life-threatening. Acute alcohol intoxication strongly inhibits gluconeogenesis.
That's the liver making new glucose.
Right, making glucose from sources like amino acids or lactate, which is vital when you're not eating. Alcohol blocks this process and also depletes the liver's stored glycogen.
So blood sugar can plummet.
Yes, leading to severe hypoglycemia. And importantly, the body's usual counter-regulatory hormones like glucagon often fail to correct it because the liver simply can't produce glucose. Meaning if someone presents unconscious or confused from alcohol, you must check their blood sugar, and if it's low, IV glucose infusion is mandatory and urgent. You can't wait.
What about reproductive effects? The perception versus reality.
Alcohol notoriously lowers inhibitions, which might lead to increased sexual interest or risky behavior, but physiologically, it impairs sexual performance significantly in both men and women.
And chronic abuse.
Devastating effects long-term. Impotence, testicular atrophy, shrinkage in men, gynecomastia, breast enlargement in men due to hormonal disruption, and infertility issues in both sexes. #tag3free, pharmacokinetics, metabolism, and elimination.
All right, let's track alcohol's journey through the body. Pharmacokinetics, this is vital for understanding impairment, testing, all of that. How is it absorbed?
Very efficiently. Some absorption happens in the stomach, but it's much slower there than in the small intestine. So the key factor dictating how fast alcohol hits your bloodstream is gastric emptying time.
meaning food in the stomach slows it down.
Exactly. Food delays the stomach from emptying its contents into the intestine, slowing absorption. On an empty stomach, alcohol passes through quickly, gets absorbed rapidly from the intestine, and peak blood levels can occur in just 30 minutes or so.
Is there much first-pass metabolism, like broken down before it reaches the main circulation?
There's a little bit in the stomach wall and the liver, but it's generally limited, especially with rapid absorption. It doesn't prevent a significant amount from reaching the bloodstream quickly.
And once it's in the blood, where does it go? Distribution.
It distributes very widely throughout the body water. Its volume of distribution is around 0.7 liters per kilogram, which is roughly total body water.
Does it get into the brain easily?
Very easily. It crosses the blood-brain barrier without trouble, so brain concentration rapidly equilibrates with blood concentration. And critically, it also crosses the placenta freely, exposing a fetus directly.
Okay, now for maybe the most unique aspect, metabolism. How does the body break down ethanol?
About 98% of it is metabolized, primarily in the liver, through a two-step oxidation process.
Step 1.
The main enzyme is alcohol dehydrogenase, ADH. It converts ethanol into acetaldehyde.
Which we already identified as toxic.
Right. But normally, step 2 happens very quickly. Another enzyme, aldehyde dehydrogenase, ALDH, converts that acetaldehyde into acetate.
And acetate is harmless.
Relatively harmless, yeah. It's basically vinegar. It can then be further broken down into carbon dioxide and water through normal metabolic pathways like the Krebs cycle.
Is everyone's ADH and ALDH the same?
Not at all. There's significant genetic variability, especially in ADH activity. Different gene variants mean some people metabolize alcohol much faster or slower than others. This underlies some of the population differences in alcohol tolerance and flushing reactions.
Is there another minor pathway for metabolism?
Yes, a small amount, especially with chronic heavy drinking, is oxidized by microsomal enzymes in the liver, mainly CYP2E1. This pathway becomes more important when ADH is saturated or induced.
Which brings us to the absolute cornerstone concept here, zero-order kinetics. What does that mean, and why is it so unusual for drugs?
Most drugs follow first-order kinetics. That means the body eliminates a constant fraction or percentage of the drug per unit of time. So the higher the concentration, the faster the elimination rate in absolute terms.
But alcohol is different.
Completely different. Because the primary enzyme, ADH, gets saturated, meaning it's working at its maximum capacity at very low blood alcohol concentrations, relevant even after just 1 or 2 drinks.
So once saturated,
the metabolism proceeds at a constant amount per unit of time, regardless of how much alcohol is in the blood. This is zero-order kinetics.
a fixed amount, not a fixed percentage. What's the typical rate?
The body can typically metabolize about 8 to 12 milliliters of absolute alcohol per hour. That's roughly 1 standard drink per hour, give or take, based on individual factors.
And this rate is constant. It doesn't speed up if you drink more.
No. Once saturated, the enzyme works at its Vmax, its maximum velocity. Drinking more just leads to accumulation because intake exceeds the fixed elimination rate.
So this explains why you can't just sober up quickly. Coffee, cold showers. None of that speeds up the enzyme.
Absolutely correct. Those things might make you feel more awake, but they do nothing to accelerate the biochemical process of breaking down ethanol. Only time works, allowing that enzyme system to slowly clear the alcohol at its fixed rate.
This is why the rate of drinking is so critical for intoxication levels.
Precisely. If you drink faster then, your body can clear it faster than about 1 drink per hour, your BAC will rise.
Okay. What about excretion? Does much leave the body unchanged?
Very little. Only about 2% is excreted unchanged, mostly via the kidneys and urine and the lungs and breath.
But that breath excretion is incredibly important legally.
Yes, forensically crucial. The concentration of alcohol in deep lung, alveolar air is directly proportional to the concentration in the blood. The ratio is very consistent.
What is the ratio?
Alcohol concentration in breath is about 0.05% of the concentration in the blood. Or, put another way, the blood-to-breath ratio is about 2100.1. This stable relationship is the scientific basis for breathalyzers used in law enforcement. #TAG-V. Clinical implications, interactions, and safe use.
Understanding how alcohol interacts with other drugs is obviously vital for safety. Let's start with synergy when effects add up dangerously.
Alcohol shows marked synergism with basically all other CNS depressants. Think benzodiazepines for anxiety, sleeping pills, opioid painkillers, even some older antihistamines that cause drowsiness.
Combining them leads to
Much deeper sedation, respiratory depression, loss of coordination, increased risk of accidents, coma, or even death. The effects aren't just additive, they can be multiplicative.
Now, that CYP enzyme interaction we touched on earlier, acute versus chronic drinking has different effects.
Yes, this is a key point. Acute alcohol intake tends to inhibit some CYP enzymes, but chronic heavy drinking leads to induction and increase in certain CYPs, especially CYP2E1.
And this induction creates a specific severe risk with one common painkiller.
Paracetamol, or acetaminophen. Normally, most paracetamol is metabolized safely, but a small amount is converted by CYP enzymes, including CYP2E1, into a toxic metabolite called NABQI.
Okay.
Usually, the liver quickly neutralizes NABQI with glutathione, but in a chronic alcoholic, two things happen. Their CYP2E1 is induced, so they make more NABQI from paracetamol, and their glutathione stores are often depleted from the alcohol abuse itself.
A perfect storm for liver damage.
Exactly. They are exquisitely sensitive to paracetamol toxicity. Even doses considered normal or therapeutic for others can cause severe, potentially fatal liver failure in a chronic alcoholic. Their safe dose limit is much, much lower.
What about interactions with diabetes medications?
Alcohol can significantly enhance the blood sugar lowering effects of both insulin and oral sulfonylurea drugs. This increases the risk of dangerous hypoglycemia. Careful monitoring is essential.
And with common anti-inflammatories.
Taking alcohol with aspirin or other NSAIDs substantially increases the risk of gastric irritation and bleeding. Both substances can damage the stomach lining.
Then there are those weird disulfiram-like reactions. What's that about?
This happens when someone drinks alcohol while taking certain specific drugs. The classic example is disulfiram itself, Antabuse, used to treat alcoholism, but it can also occur with the antibiotic metronidazole, some cephalosporin antibiotics like ceftriaxone, and maybe some older sulfonylureas.
What does the reaction look like?
It mimics the effects of acetaldehyde buildup. Intense flushing, throbbing headache, nausea, vomiting, sweating, possibly confusion, and circulatory collapse. It's very unpleasant and potentially dangerous. The exact mechanism isn't always clear for drugs other than disulfiram, but it involves interference with acetaldehyde metabolism.
Okay, let's list the absolute contraindications. When should someone definitely not drink alcohol?
The list is pretty clear for achieving that professional mastery we're aiming for. Number 1, peptic ulcer disease, severe hyperacidity, or GERD. Alcohol increases acid and relaxes the LES.
Makes sense.
Epilepsy. While alcohol might temporarily suppress seizures during intoxication, the withdrawal phase significantly lowers the seizure threshold, potentially triggering fits.
Okay.
Anyone with severe liver disease, obviously. The liver is the primary site of metabolism and damage. Also, individuals with a history of pancreatitis.
Personality factors.
Unstable personalities or those with a history of substance abuse are at very high risk for developing alcohol dependence.
And the most critical one, perhaps, pregnancy.
Absolutely non-negotiable. There is no known safe level of alcohol consumption during pregnancy. Even moderate drinking risks fetal alcohol syndrome, FAS.
Remind us what FAS involves.
It's a devastating pattern of birth defects. Permanent growth retardation, both before and after birth, reduced intelligence, low IQ, microcephaly, small head size, characteristic facial abnormalities like small eye openings and a thin upper lip, and often other organ system problems, plus impaired immune function.
And heavier drinking.
Increases the risk of miscarriage, stillbirth, and low birth weight, in addition to the risk of full-blown FAS or related alcohol-related neurodevelopmental disorders, ARND. Complete abstinence during pregnancy is the only safe course.
Given how common drinking is, what do guidelines generally consider safe or low-risk drinking limits for adults who choose to drink?
Balancing potential risks and the limited potential benefits, general guidelines often suggest. An average safe limit is around 1 to 2 standard drinks per day for men and often less for women.
And a maximum on any single occasion.
Typically advised not to exceed 3 drinks on any one occasion. Consuming more than 3 drinks per day regularly clearly pushes into higher risk territory for adverse effects like hypertension, certain cancers, and liver issues.
Why are the limits generally lower for women?
It's mainly pharmacokinetic differences. Women generally have lower levels of alcohol dehydrogenase in the stomach lining, meaning less first-pass metabolism occurs there. They also tend to have a lower percentage of body water and higher percentage of body fat than men of the same weight.
Resulting in
higher peak blood alcohol concentrations from the same amount of alcohol consumed. Metabolism might also be slightly slower on average.
And just to be clear, what constitutes one standard drink?
It varies slightly by country, but a common definition is around 14 to 16 grams of pure alcohol. That translates roughly to 50 milliliters, a standard shot of spirits, like whiskey or vodka, about 150 milliliters, a small glass of wine, or around 350, 400 milliliters, a standard bottle or can of regular strength beer. Knowing these equivalents is important. Hashtag tag check, sexes, toxicity, chronic abuse, and treatment.
Let's talk about acute intoxication as a medical emergency. Beyond the stupor and coma, what are the immediate life threats?
We've mentioned respiratory depression and potential cardiovascular collapse, hypotension, but two other critical risks are profound hypoglycemia, as we discussed,
Right, the blocked gluconeogenesis.
and the high risk of vomiting and aspiration. Alcohol irritates the stomach, and if someone vomits while their consciousness and protective airway reflexes are depressed, they can inhale stomach contents into their lungs.
Which can be fatal.
Yes, aspiration pneumonia is a very serious complication.
So in treating acute alcohol poisoning, what's the absolute first priority?
Airway, breathing, circulation, ABCs, as always in emergency medicine. Specifically, maintaining a patent airway and preventing aspiration is paramount. This might mean positioning the patient carefully or even performing tracheal intubation early on.
Then supportive care?
Fluids, electrolyte correction, monitoring vital signs. Importantly, avoid giving CNS stimulants or analeptics.
Why no stimulants? Wouldn't that help wake them up?
It increases the risk of seizures dramatically. The brain is already in a volatile state, swinging between depression and potential hyperexcitability during recovery. Stimulants just pour fuel on that fire.
And the essential medications.
Two things are often crucial. First, check blood glucose and give IV glucose immediately if low or if levels can't be checked quickly. Second, administer thiamine, vitamin B1, usually 100 milligram IV or IM.
Why is thiamine so important here?
Chronic alcoholics are almost universally deficient in thiamine. Giving glucose without thiamine can actually precipitate Wernicke's encephalopathy, a serious neurological emergency. So thiamine should always be given alongside or just before glucose in suspected alcoholics.
Okay. Shifting to chronic use. Tolerance develops, right? People need more alcohol for the same effect.
Yes, but the degree of tolerance is relatively low compared to, say, opioids. It involves both pharmacokinetic tolerance, the liver enzymes get induced, maybe absorption changes slightly.
And cellular tolerance.
Right. The brain cells adapt to the constant presence of alcohol, adjusting receptor numbers or sensitivity, like down-regulating GABA receptors or up-regulating NMDA receptors, to try and counteract its effects. Dependence really sets in with persistent heavy drinking that keeps blood levels elevated.
What drives someone to become dependent? Is it just genetics?
Genetics plays a significant role, maybe contributing around 50% of the risk. But it's complex. Learned behaviors, social environment, using alcohol to cope with stress or mental health issues, cultural norms. It's a mix of factors.
The complications of chronic alcoholism are widespread, but particularly severe neurologically, often linked back to that thiamine deficiency.
Absolutely. Peripheral neuropathy, nerve damage in limbs causing pain or numbness, tremors, increased risk of seizures even outside of withdrawal, and actual brain damage leading to cognitive decline and loss of brain mass.
And the specific syndromes, Wernicke's and Korsakoff's.
Wernicke's encephalopathy is the acute stage, often triggered by giving glucose without thiamine. It presents as a triad of confusion, ataxia, difficulty walking, and specific eye movement problems. Nystagmus, ophthalmoplegia. It's a medical emergency requiring immediate high-dose thiamine.
And if not treated promptly.
It can progress to Korsakoff's psychosis, which is characterized by severe, often permanent, anterograde and retrograde amnesia, memory loss, and confabulation, making up stories to fill memory gaps. Damage to specific brain areas like the mammillary bodies and thalamus is involved.
Other major chronic complications besides neurological and liver.
We mentioned hypertension, cardiomyopathy, stroke risk, pancreatitis. There's also a significantly increased risk of certain cancers, especially mouth, throat, esophagus, liver, and possibly breast cancer. And chronic alcohol abuse suppresses the immune system, making individuals more prone to infections like pneumonia and tuberculosis.
When a dependent person stops drinking abruptly, they face withdrawal. What does that look like?
It's basically the CNS rebounding into a state of severe hyperexcitability because it's no longer suppressed by alcohol. Symptoms usually start within hours to a day or two.
What are the typical symptoms?
Anxiety, agitation, sweating, rapid heart rate, insomnia, intense tremors, the shakes. It can progress to confusion, visual or auditory hallucinations.
In the most severe form.
Delirium tremens, DTs. This is a medical emergency characterized by severe confusion, disorientation, terrifying hallucinations, extreme agitation, fever, tachycardia, and potentially seizures and cardiovascular collapse. It has a significant mortality rate if untreated.
How is alcohol withdrawal managed pharmacologically? You need to calm that hyperexcitable brain.
The mainstay is substitution therapy, using long-acting benzodiazepines. Drugs like chlordiazepoxide or diazepam are commonly used
Why benzodiazepines?
because they also work by enhancing GABAergic inhibition, similar to alcohol. So they effectively substitute for the alcohol, suppressing the withdrawal symptoms. Their long duration allows for a slow, gradual tapering of the dose over days, letting the brain readjust safely.
Okay, that's for managing acute withdrawal. What about preventing relapse long term? Are there medications to help with craving or the rewarding effects?
Yes, there are several FDA-approved options. One major one is naltrexone.
How does naltrexone work?
It's a long-acting opioid receptor antagonist. Remember how alcohol's rewarding dopamine release seems to involve beta-endorphin acting on opioid receptors?
Right?
Naltrexone blocks those opioid receptors. It doesn't stop someone from drinking, but it seems to blunt the pleasurable, rewarding high they get from it. This reduces craving and makes relapse less likely.
Another option is a camprosate.
A camprosate, yes. Its exact mechanism is still being worked out, but it seems to help stabilize the neurotransmitter systems that are disrupted by chronic alcohol use and withdrawal. It appears to be a weak NMDA receptor antagonist and might have some activity-enhancing GABA function.
How effective is it compared to naltrexone?
Studies suggest its efficacy is comparable to naltrexone in helping maintain abstinence. Sometimes they're used together or sequentially.
And then there's the oldest approach,
Yeah.
aversion therapy with disulfiram.
Disulfiram antabuse. This works very differently. It's not about reducing craving, it's about creating a strong deterrent.
Oh.
Disulfiram irreversibly inhibits the enzyme aldehyde dehydrogenase, ALDH, the one that breaks down toxic acetaldehyde.
So if someone on disulfiram drinks alcohol,
Acetaldehyde builds up rapidly to very high toxic levels. This causes the intensely unpleasant aldehyde syndrome we mentioned. Severe flushing, pounding headache, nausea, violent vomiting, dizziness, chest pain, potentially collapse.
sounds brutal. Who is it suitable for?
Only highly motivated patients who are already abstinent and fully understand the consequences of drinking while taking it. It requires supervision and commitment because the reaction can be dangerous. It essentially enforces sobriety through fear of the reaction.
Are there any other promising drugs being looked at?
Yes, research is ongoing. Some studies suggest potential benefits from the anti-nausea drug ondansetron, a 5-HT3 antagonist, and the anti-epileptic drug topiramate, which might reduce cravings, but they're generally considered off-label or adjuvant therapies for now. #tag7, methanol and ethylene glycol poisoning, the toxic derivatives.
Okay, we absolutely have to cover the toxic alcohols, starting with methanol or methyl alcohol, found in windshield washer fluids, some solvents, and used to denature ethanol. Why is it so much more dangerous than ethanol?
The danger lies entirely in its metabolism. Like methanol itself isn't extremely toxic, but it gets metabolized by the same liver enzymes. Alcohol dehydrogenase, ADH, followed by aldehyde dehydrogenase, ALDH.
But the process is different.
Yes, two crucial differences.
Yeah.
First, ADH metabolizes methanol much slower than ethanol, about 1/7 the rate. Second, the breakdown products are highly toxic.
What are the products?
ADH converts methanol to formaldehyde. Then ALDH, or another enzyme, quickly converts formaldehyde to formic acid.
Formaldehyde and formic acid sound bad.
They are, especially formic acid. Its clearance is very slow and depends on folate, so formic acid accumulates.
And what does formic acid do?
It causes severe metabolic acidosis. And crucially, formic acid has a specific toxicity for the retina and optic nerve.
Leading to blindness.
Exactly. The characteristic symptoms of methanol poisoning, which are often delayed for 12-24 hours as metabolites build up, include visual disturbances, blurred vision, spots, eventually leading to permanent blindness. This visual damage often precedes death, which usually occurs from respiratory failure due to the profound acidosis.
How much methanol is fatal?
It can be surprisingly little. Fatalities have been reported with ingestions as low as 30 milliliters, and severe toxicity or blindness can occur with even less. Maybe 75-100 milliliter is often cited as a typically fatal dose.
So treatment hinges on stopping that metabolism, since it uses the same enzyme, ADH.
Precisely. The core strategy is competitive inhibition of alcohol dehydrogenase. You give the enzyme something else it prefers to work on to block it from metabolizing the methanol.
And the classic way was using ethanol itself.
Correct. Administering intravenous or sometimes oral ethanol to achieve and maintain a blood ethanol concentration of around 100 milligdl effectively fools the ADH enzyme. ADH has a higher affinity for ethanol, so it gets busy metabolizing the ethanol, leaving the methanol unmetabolized so it can be slowly excreted by the kidneys and lungs.
But giving ethanol to a critically ill patient has downsides.
Big downsides. It causes intoxication, can worsen sedation or confusion, carries a risk of hypoglycemia, and requires very careful monitoring of blood levels.
So what's the modern drug of choice?
Fomepizole, brand name Antizol. It's a direct, potent inhibitor of alcohol dehydrogenase.
Advantages of fomepizole.
It's much easier to administer via regulated IV infusion. It doesn't cause intoxication, has a longer duration of action, and is highly effective. It's now the standard of care wherever available.
Besides blocking metabolism, what else is crucial in treatment?
Aggressively treating the metabolic acidosis with intravenous sodium bicarbonate. This is probably the single most important measure to limit the damage, especially to the eyes. Raising the blood pH helps convert formic acid to the less toxic formate ion and promotes its excretion.
Any other treatments?
Hemodialysis can be very effective at removing both methanol and formic acid directly from the blood, especially in severe cases. And giving folate, as leucovorin or folinic acid, might help accelerate the slow breakdown of formic acid.
Okay, briefly, what about ethylene glycol poisoning? That's the main component of antifreeze. Similar pathway.
Very similar initial step. Ethylene glycol is also metabolized by alcohol dehydrogenase, ADH.
To what?
It goes through several steps, producing toxic intermediates like glycolaldehyde and glycolic acid, which cause acidosis. But the major end-stage toxic metabolite is oxalic acid.
Oxalic acid that forms crystals.
Exactly. Oxalic acid precipitates with calcium in the blood and tissues, forming calcium oxalate crystals. These crystals deposit primarily in the renal tubules, causing severe acute kidney injury and failure. It also causes profound acidosis and can affect the heart and lungs.
So the treatment approach is the same, block ADH.
Yes. Because ADH is the first critical step, fomepizole is also the drug of choice for ethylene glycol poisoning. Ethanol therapy is the alternative if fomepizole isn't available. Supportive care, bicarbonate for acidosis, and often hemodialysis to remove ethylene glycol and its toxic metabolites are also key. #tag 8, conclusion, and final takeaways.
Wow. We have covered a massive amount of ground today, from the basics of fermentation hitting that 15% natural limit,
It's a historical gunpowder test for proof spirit,
through the complex dance of GABA enhancement and NMDA blockade in the brain.
landing on that absolutely critical concept of zero-order kinetics, that constant fixed rate of elimination, 8 to 12 milliliters per hour, no matter what.
And understanding the life-saving difference in treating methanol or ethylene glycol poisoning using competitive inhibition with fomepizole or ethanol to block ADH. That's true professional level knowledge.
Absolutely. We also saw that outside beverage use, ethanol's roles are pretty limited, mostly external antiseptic or astringent, maybe that specialized nerve block for pain.
And we covered the critical treatment points.
Yeah.
Glucose and thiamine for acute intoxication, benzodiazepines for withdrawal, and the targeted agents like naltrexone or camprosate aiming to reduce relapse by modulating reward or stabilizing neurotransmitters.
And disulfiram, the enforcer.
Right. But one thing our sources highlighted, and it's worth repeating, is the disconnect. The core pharmacology is neuronal depression, pure CNS depression.
Yet the behavioral outcomes are incredibly varied. Happy drunk, sad drunk, angry drunk, sleepy drunk. The pharmacology alone doesn't explain that range.
Attitude, expectations, the social setting, learned behaviors, they all massively influence how someone acts when intoxicated.
Which brings us to the final takeaway, perhaps a provocative thought for you, the listener.
If we've achieved this elite professional mastery, if you now truly grasp that your body metabolizes alcohol at a slow, fixed, biologically immutable rate dictated by zero-order kinetics,
Around 1 drink per hour, Bax.
how do you reconcile that hard biochemical reality with the often intense social pressures or ingrained habits that encourage drinking much faster than that?
The science is clear. Your liver has a speed limit. But human behavior, influenced by psychology and environment, often ignores that limit completely. Understanding that gap between the fixed pharmacology and the variable human response might be just as important as knowing the enzymes and receptors.
A really crucial point to consider, where the chemistry meets culture and conditioning. Thank you for joining us on this very deep dive into the pharmacology of alcohol. We hope this detailed exploration serves you well.